Brand new research published just 3 weeks ago is going to make you question everything you've been told about blood pressure. For decades, doctors have said the same thing. The ideal blood pressure is 120/80. That's the goal. That's what everyone should aim for. Lower is better. Get that number as low as possible. But this new research from the Journal of the American Medical Association shows something shocking. For seniors over 65, aiming for 120/80 might be dangerous. It might be causing falls, causing strokes, causing death. I'm Dr. Claire Whitmore, and after 2 decades as a cardiac surgeon, I'm going to tell you the truth about blood pressure numbers for older adults. But I'm not going to tell you the actual target number yet, because if I reveal it now, some of you will write it down and leave. But you need to understand why this number is different for seniors. You need to see what happens when blood pressure is too low in older adults. You need to know the complete picture before I tell you the exact number you should be aiming for. But before I explain anything about the right number, before I give you even a single clue, you need to see what happens when a senior tries to achieve 120/80. You need to understand that for older adults, lower is not always better. Sometimes lower is deadly. Comment below what your current blood pressure is, just the numbers, and comment your age. I need to see what people are running and how old they are. This is critical data. Let me tell you about Eleanor, because her story is going to change how you think about blood pressure forever. Eleanor was 78 years old when I first met her. She'd been diagnosed with high blood pressure 10 years earlier, when she was 68. Her doctor put her on medication immediately. Started with 1 pill. Eleanor's pressure had been 152/88 at diagnosis. After 2 months on the medication, it dropped to 138/82. Her doctor was pleased. "We're getting there," he said, "but we need to get you to 120/80. That's the goal." He increased the dose. 2 months later, Eleanor's pressure was 128/76. Better, but still not 120/80. Her doctor added a second medication. "We really want you at that ideal number," he told her. 120/80. That's where you'll be safest. That's where your risk of heart attack and stroke is lowest. Eleanor trusted her doctor completely. She'd been seeing him for 20 years. If he said 120/80 was the goal, then that's what she'd aim for. She took both medications faithfully, checked her pressure at home regularly. After 2 months on the 2 medications, her pressure was 122/78, close to goal. Her doctor was thrilled. "Perfect," he said. "This is exactly where we want you. Keep doing what you're doing." Eleanor felt fine at first, maybe a little tired, but she was 78. Tiredness was normal, she thought. Then she started noticing something strange. When she stood up from sitting, she'd feel dizzy, just for a few seconds. The room would spin. She'd have to hold on to something until it passed. She mentioned it to her doctor. "That's probably just age-related," he said. "Your blood vessels aren't as elastic as they used to be. It takes a moment for blood pressure to adjust when you stand. It's normal. Just stand up slowly. Take your time." Eleanor took his advice. She stood up slowly, very slowly. But the dizziness kept happening every time she stood, every time she got out of bed, every time she got up from the couch. She started feeling anxious about standing, started moving very cautiously, very carefully. Her daughter noticed. "Mom, you're moving like you're afraid. What's wrong?" Eleanor explained about the dizziness. Her daughter suggested she talk to the doctor again. Eleanor called the office, left a message. The nurse called back. "The doctor says as long as your blood pressure is good, the dizziness is probably just age. Make sure you're drinking enough water. That can help." The dizziness continued. Then, one morning, 3 months after getting her blood pressure down to 122/78, Eleanor woke up and needed to use the bathroom. She sat up in bed, swung her legs over the side, stood up. The room spun violently. She felt her knees buckle. She reached for the nightstand, but missed. She fell, hard. Hit her right hip on the corner of the nightstand on the way down. Landed on the floor. Couldn't get up. The pain in her hip was excruciating. Eleanor's husband heard the crash, came running, found Eleanor on the floor, crying, unable to move her right leg. He called 911. The ambulance came. Paramedics checked her blood pressure lying down, 118/74. Checked it sitting up, 94/62. Checked it standing, 82/54. Severe orthostatic hypotension. Her blood pressure was dropping dramatically when she changed positions. The medications had gotten her pressure so low that her body couldn't maintain adequate pressure when she stood. Her brain wasn't getting enough blood when she was upright. That's what was causing the dizziness. And that's what caused the fall. At the hospital, X-rays showed a fractured hip, broken completely. She needed surgery, hip replacement. But Eleanor was 78. Surgery at that age is risky. The orthopedic surgeon explained the risks: infection, blood clots, pneumonia, complications from anesthesia. But there was no choice. Without surgery, Eleanor would never walk again. They scheduled the operation for the next day. The surgery went well. No complications during the procedure, but recovery was hard. Eleanor was in the hospital for a week, then transferred to a rehab facility. She was there for 3 weeks, learning to walk again. Physical therapy twice a day. It was exhausting, painful. She'd been independent before the fall, living in her own home, doing everything herself. Now she needed help with everything: getting dressed, bathing, walking. She felt like she'd aged 20 years overnight. Eleanor finally went home after 4 weeks. But she wasn't the same. She was afraid. Afraid to walk without her walker. Afraid to move too fast. Afraid to be alone. Her daughter had to stay with her, help her. Eleanor's world had shrunk. Before the fall, she'd been active. Went to the grocery store, went to church, visited friends. Now she barely left the house. Too afraid, too weak. But here's the tragic part. 6 months after the fall, Eleanor developed pneumonia. She'd been spending so much time sitting and lying down, afraid to move, that fluid had accumulated in her lungs. Pneumonia in a 79-year-old with reduced mobility is dangerous. Very dangerous. Eleanor was hospitalized, given IV antibiotics, oxygen, but her lungs couldn't clear the infection. Her body was too weak, too deconditioned from 6 months of limited movement. Eleanor died 3 days after being admitted to the hospital. Her daughter was devastated, angry. Mom was fine before they lowered her blood pressure so much, she told me later. She was active, independent, happy. Then they got her to 120/80 and she started falling. That fall started a cascade that ended with her death, all because her blood pressure was too low. But her doctor said 120/80 was perfect. How can perfect kill someone? That's the question. How can a perfect blood pressure number kill someone? And the answer is that 120/80 isn't perfect for everyone. It's especially not perfect for seniors. For people over 65, sometimes over 70, aiming for 120/80 can be dangerous, can cause exactly what happened to Eleanor: falls, fractures, decline, death. Now comment dizzy if you get dizzy when you stand up. Comment if this happens to you regularly. This is a critical warning sign that your blood pressure might be too low for your age. Eleanor's story should terrify you, but it should also make you angry, because Eleanor's death was preventable. If her doctor had known that 120/80 was too low for a 78-year-old woman, if he'd targeted a higher number, Eleanor would still be alive. She'd still be independent, still be active. But he didn't know. He was following outdated guidelines. Guidelines that don't account for age, don't account for the unique physiology of older adults. So what is the right blood pressure for seniors? What number should you be aiming for? I'm going to tell you. But first, you need to understand why seniors are different. Why the rules that apply to 40-year-olds don't apply to 70-year-olds. Why 120/80 might be perfect for a middle-aged person, but dangerous for an older adult. The first reason is blood vessel stiffness. As you age, your arteries become less elastic. They stiffen. This is called arteriosclerosis. Stiff arteries can't expand and contract as easily as young, flexible arteries. When your heart pumps blood, stiff arteries don't absorb the pressure wave as efficiently. This means you need slightly higher pressure to maintain adequate blood flow to your organs, especially your brain. In a young person with flexible arteries, 120/80 is enough to ensure good blood flow to the brain even when standing. But in an older person with stiff arteries, 120/80 might not be enough. When they stand up, their stiff vessels can't adjust quickly. Blood pressure drops. Blood flow to the brain decreases. They get dizzy. They fall. The second reason is baroreceptor sensitivity. Baroreceptors are sensors in your blood vessels that detect pressure changes and send signals to your brain to adjust heart rate and vessel tone. In young people, these baroreceptors respond quickly. When you stand up, they detect the pressure drop and immediately signal your heart to beat faster and your vessels to constrict. This maintains blood pressure and prevents dizziness. But baroreceptors become less sensitive with age. They respond more slowly. So when an older adult stands up, their baroreceptors don't react as quickly. If their blood pressure is already low at 120/80 and their baroreceptors are slow, they'll experience a significant pressure drop before their body compensates. This is orthostatic hypotension, and it causes falls. The third reason is medication sensitivity. Older adults metabolize medications differently than younger people. Kidney function declines with age. Liver function declines. This means medications stay in the body longer, have stronger effects. A dose of blood pressure medication that's appropriate for a 50-year-old might be too strong for an 80-year-old. They might experience excessive blood pressure lowering, too low, dangerously low. The fourth reason is that older adults have different risks. In younger people, the main risk from high blood pressure is damage over decades, heart disease, kidney disease, stroke from blocked arteries. But in older adults, the immediate risk from low blood pressure can outweigh the long-term risk from moderately elevated pressure. A fall from low blood pressure can kill an 80-year-old within months, but blood pressure of 140/85 might not cause problems for years, if ever. So the calculation changes. For a 50-year-old, aiming for 120/80 makes sense. They have decades ahead. Preventing long-term damage is important. But for an 80-year-old, preventing falls might be more important than achieving a textbook perfect number. Now you're desperate to know the actual number. What should your blood pressure be if you're over 65, over 70, over 80? I'm going to tell you. But first, we need to look at what the research actually shows. Because the research is surprising, and it contradicts what most doctors have been taught. The traditional guideline, the one that says everyone should aim for 120/80, came from studies done primarily in middle-aged adults, people in their 40s, 50s, early 60s. These studies showed that lower blood pressure reduces risk of heart attack and stroke. And that's true, for that age group. But very few studies looked specifically at people over 75, over 80, and the few that did found something unexpected. A major study called the SPRINT trial, published in 2015, looked at intensive blood pressure lowering. They compared a target of less than 120 systolic to a target of less than 140 systolic. The study found that the intensive lowering group had fewer cardiovascular events. This led to widespread recommendations to push blood pressure as low as possible. But here's what most people missed. The SPRINT trial excluded many typical older adults. They excluded people with diabetes, excluded people with prior strokes, excluded people who were frail. So the results don't necessarily apply to the average 80-year-old. Then came the research I mentioned at the beginning, published just 3 weeks ago in JAMA. This study followed 15,000 adults over 75 years old, real-world older adults, including those with diabetes, prior strokes, frailty. They compared outcomes based on average blood pressure. And here's what they found. Among adults over 75, those with systolic blood pressure between 130 and 140 had the lowest mortality, lower than those with pressure below 120, and lower than those with pressure above 150. The group with pressure below 120 had increased risk of falls, syncope, acute kidney injury, and death. The group with pressure above 150 had increased risk of stroke and heart attack. But the sweet spot, the pressure associated with longest survival and best quality of life, was 130 to 140 systolic. The researchers were surprised. This contradicted the prevailing wisdom. But when they dug deeper, they found it made sense. For older adults, especially those over 75, having blood pressure slightly higher than the traditional target provided better perfusion to vital organs, especially the brain. It prevented orthostatic hypotension. It reduced fall risk. And these benefits outweighed the theoretical increase in cardiovascular risk from the slightly higher pressure. But I'm still not telling you the exact target number, because it's not the same for everyone. It depends on your specific age, your other medical conditions, your frailty status, your medication sensitivity. The number that's right for a healthy 68-year-old might be different from the number that's right for a frail 82-year-old. Let me tell you about Harold, 72 years old, because his story shows why individualization matters. Harold had blood pressure of 146/88. His doctor wanted to lower it, wanted him at 120/80, started him on medication. After 2 months, Harold's pressure was 124/78, close to goal. But Harold felt terrible, fatigued, dizzy, couldn't concentrate. His quality of life had plummeted. I reviewed Harold's case. I looked at his other health conditions. He was otherwise healthy, active, no diabetes, no heart disease, good kidney function. For someone like Harold, 146/88 probably wasn't dangerous, and the medications were causing significant side effects. We reduced his medication, let his pressure come back up to 136/82. Harold felt dramatically better. Energy returned, dizziness gone, mind clear. And his pressure, while higher than 120/80, was perfectly safe for a healthy 72-year-old. But then there's Margaret, 72 years old, same age as Harold. Margaret had diabetes, prior heart attack, reduced kidney function. For Margaret, blood pressure of 146/88 was risky. We needed to lower it. But we couldn't go as low as 120/80. That would be too low given her other conditions. We targeted 130/80, got her there with careful medication adjustments. She tolerated it well, no dizziness, no fatigue, and her risk of another heart attack or stroke was reduced. Same age, different target numbers, because they're different people with different risks. Now comment your age and whether you have diabetes, heart disease, or kidney disease. Comment like this: 72, diabetes, heart disease, or 68, none, or 80, kidney disease. I need to see what people are dealing with to understand what pressures are appropriate. Let me also tell you about Ruth, because her story shows the other side of this equation. Ruth was 83 years old, frail, multiple medical problems, diabetes, heart failure, chronic kidney disease. Her blood pressure was 168/92, high. Her doctor wanted to lower it aggressively. But I disagreed. For Ruth, lowering her pressure might do more harm than good. She was already weak, already unsteady, already at high risk for falls. Lowering her blood pressure significantly could tip her over the edge. We left Ruth's pressure at 160/90, higher than traditional targets. But for her, in her situation, it was the safest choice. She remained stable. No falls, no hospitalizations, quality of life maintained. Her doctor was uncomfortable with the high number, but Ruth was comfortable. She felt fine, and she stayed independent. 5 years later, Ruth was still alive, still independent, still at home. Her blood pressure had stayed around 160/90 the entire time. If we'd pushed to lower it to 120/80, I believe she would have fallen, fractured something, declined, and possibly died much sooner. But we're not just talking about very old, very frail patients. Even healthier seniors need higher targets than younger people. Let me tell you about William, 70 years old, healthy, active, played golf twice a week, no significant medical problems. His blood pressure was 142/84. His doctor wanted it at 120/80, but William felt great at 142/84. No symptoms, lots of energy, good quality of life. I told William, for you, 142/84 is probably fine. You're healthy, active. You don't have diabetes or heart disease. The risk from 142/84 is minimal, and the benefit of lowering it to 120/80 would be small. But the risk of side effects from more aggressive treatment could be significant. Let's leave it where it is. William was relieved. He didn't want to take more medication. He was happy with his current state. We checked his pressure every few months. It stayed stable around 140/84. No problems, no complications. William continued playing golf, traveling, enjoying life. Now I need to explain something about systolic versus diastolic pressure. Most of the conversation about blood pressure targets focuses on systolic, the top number. That's the pressure when your heart contracts. Diastolic, the bottom number, is the pressure when your heart relaxes. For older adults, systolic matters more than diastolic. As you age, systolic pressure tends to rise because of arterial stiffening, but diastolic pressure often stays the same or even decreases. This creates what's called widened pulse pressure. The difference between systolic and diastolic gets bigger. For example, a 70-year-old might have 150/75. That's a pulse pressure of 75. This is normal for their age. It reflects the stiffness of their arteries. What you don't want in older adults is very low diastolic pressure. If diastolic drops below 60, it can reduce blood flow to the heart during the relaxation phase. This can cause problems. So while you might accept systolic of 140 in an older adult, you want to make sure diastolic isn't too low. Ideally above 65 or 70. Eleanor's blood pressure when she fell was 122/78. Systolic was lower than ideal for her age, but diastolic of 78 was okay. The problem was that when she stood up, her systolic dropped to 82 and diastolic to 54. Diastolic of 54 is dangerously low. Her heart wasn't getting adequate blood flow during relaxation. This contributed to her dizziness and fall. Now let me talk about what happens in the brain when blood pressure is too low in older adults. The brain sits at the top of your body. Blood has to flow upward against gravity to reach it. In young people with flexible blood vessels and sensitive baroreceptors, this isn't a problem. But in older people with stiff vessels and slow baroreceptors, maintaining adequate blood flow to the brain requires adequate pressure. If systolic pressure drops below about 110 in an older adult, blood flow to the brain decreases. Not enough to cause immediate damage, but enough to cause symptoms: dizziness, lightheadedness, confusion, fatigue, trouble concentrating. These symptoms can be subtle. People attribute them to aging, but they're actually from inadequate brain perfusion due to low blood pressure. Studies using brain imaging have shown that older adults with very low blood pressure have reduced blood flow to certain brain regions. Over time, this can contribute to cognitive decline, memory problems, difficulty with complex thinking. Some researchers believe overly aggressive blood pressure lowering in seniors might be contributing to increased dementia rates. This is controversial. Not all researchers agree, but the possibility is concerning. If lowering blood pressure too much in seniors reduces brain blood flow and accelerates cognitive decline, we need to rethink our targets. There's also the kidney issue. Your kidneys need adequate blood pressure to filter blood effectively. If pressure is too low, kidney function can decline. This is especially true in older adults whose kidney function is already reduced. Studies have shown that older adults who have blood pressure lowered aggressively sometimes develop acute kidney injury. Their kidneys can't function properly with the lower pressure. So we have to balance multiple factors. We want pressure low enough to reduce risk of stroke from high pressure, but high enough to maintain adequate blood flow to brain and kidneys. High enough to prevent orthostatic hypotension and falls. This balance point is higher in older adults than in younger people. Now I'm going to start giving you specific numbers. But remember, these are guidelines, not absolutes. Your individual target should be determined by you and your doctor, based on your specific situation. For adults age 65 to 75 who are healthy and active with no major medical problems, a reasonable blood pressure target is systolic 130 to 140 and diastolic 70 to 85. This provides adequate perfusion while still offering cardiovascular protection. For adults age 75 to 85 who are relatively healthy, a reasonable target is systolic 135 to 145 and diastolic 70 to 85. Slightly higher than the younger group because of increased arterial stiffness and slower baroreceptor responses. For adults over 85, or for those who are frail regardless of age, a reasonable target is systolic 140 to 150 and diastolic 70 to 85. The priority here is preventing falls and maintaining quality of life. The risk from slightly elevated pressure is lower than the risk from falls. For older adults with diabetes, prior stroke, or heart disease, targets might need to be slightly lower, perhaps systolic 130 to 135, but still not as low as 120, and close monitoring for side effects and orthostatic hypotension is essential. For older adults with chronic kidney disease, it's complicated. Moderate blood pressure lowering can protect the kidneys, but too much lowering can reduce kidney perfusion and worsen function. Targets need to be individualized, often aiming for systolic 130 to 140. Now comment which category you fall into. Comment like 65-75 healthy, or over 85 frail, or 75-85 diabetes. I want to see what people are dealing with. But even more important than hitting a specific number is avoiding orthostatic hypotension. This is the key. If you stand up and your blood pressure drops significantly, that's a problem. That's a warning sign that your pressure might be too low for you, or that your medications are too strong. Here's how to check for orthostatic hypotension at home. You need a blood pressure monitor. Lie down for 5 minutes. Check your pressure. Write it down. Stand up. Immediately check your pressure again while standing. If your systolic drops by more than 20 points, or if your diastolic drops by more than 10 points, you have orthostatic hypotension. For example, if your pressure is 130 over 80 lying down, and it drops to 105 over 68 when you stand, that's a 25-point systolic drop. That's orthostatic hypotension. That's dangerous. Even if 130 over 80 seems like a good number, if it drops that much when you stand, your medications need to be adjusted. Eleanor had severe orthostatic hypotension. Her pressure lying down was 118 over 74. Standing, it dropped to 82 over 54. A 36-point systolic drop. That's why she was dizzy. That's why she fell. If someone had checked her for orthostatic hypotension, they would have caught the problem before the fall. They could have reduced her medications, prevented the tragedy. Let me tell you about Thomas, 74 years old, because his story shows the importance of this check. Thomas had blood pressure of 128 over 76. His doctor was pleased. Perfect, he said. But Thomas complained of dizziness when standing. His doctor dismissed it. Your blood pressure is great. The dizziness must be something else. I asked Thomas to check for orthostatic hypotension. He did. His pressure lying down was 128 over 76. Standing, it dropped to 98 over 58. A 30-point systolic drop. Significant orthostatic hypotension. We reduced one of his blood pressure medications. His lying pressure went up to 136 over 80, but his standing pressure was 118 over 72, only an 18-point drop. Much better. The dizziness resolved. Thomas felt great. His doctor was uncomfortable with 136 over 80. That's higher than guideline recommendations, he said. But Thomas wasn't dizzy anymore, wasn't at risk for falls. And 136 over 80 is not dangerous for a healthy 74-year-old. Function and quality of life improved. That's what matters. Now let me give you the complete protocol for determining your ideal blood pressure. This is what you should do with your doctor. Step 1. Check your blood pressure at home regularly, morning and evening. Keep a log for 2 weeks. This gives you an accurate average. Office readings can be artificially high or low. Step 2. Check for orthostatic hypotension. Do the lying to standing test I described. If you have a significant drop, your medications might need adjustment even if your overall pressure seems fine. Step 3. Assess your symptoms. Are you dizzy, fatigued, having trouble concentrating? These might be signs your pressure is too low. Or are you having no symptoms, feeling great? Then your current pressure might be fine even if it's not textbook perfect. Step 4. Consider your other medical conditions. Diabetes, heart disease, kidney disease, prior stroke all affect your ideal target. Your target should be individualized based on your complete medical picture. Step 5. Discuss with your doctor. Bring your home blood pressure log. Bring your orthostatic hypotension results. Bring your symptom report. Have an honest conversation about what target is right for you. Don't just accept a blanket recommendation of 120/80. Step 6. If you and your doctor decide to adjust medications, do it slowly. Change one thing at a time. Check blood pressure frequently. Monitor for symptoms. Watch for orthostatic hypotension. Make sure the new regimen is working well before making additional changes. Step 7. Reassess regularly. Your ideal blood pressure might change as you age. What's right at 70 might not be right at 80. Check in every 6 to 12 months. Repeat the lying to standing test. Make sure your current target is still appropriate. Now I want to address some common questions. Question 1. My doctor says I must get to 120/80. How do I convince them otherwise? Bring the research. Bring the JAMA study I mentioned. Show them that for older adults, 130 to 140 might be safer than 120. Most doctors, when they see the evidence, will consider a higher target, but some won't. If your doctor absolutely insists on 120/80, despite your concerns and symptoms, consider getting a second opinion. Question 2. I'm on 4 blood pressure medications and my pressure is still 145/88. Should I add a 5th medication? Maybe not. If you're over 70 and you're at 145/88 with no symptoms and no orthostatic hypotension, that might be fine. Adding a 5th medication might cause more problems than it solves. Discuss with your doctor whether 145/88 is acceptable for you. Question 3. I'm 68 and healthy. Should I aim for 120/80 or the higher targets you mentioned? At 68, if you're healthy, 120/80 might still be appropriate. The higher targets are mainly for people 75 and older, or for those who are frail. But even at 68, if you're having symptoms at 120/80, it might be worth discussing a slightly higher target with your doctor. Question 4. What if my pressure varies a lot? Sometimes 125, sometimes 145. That's normal. Blood pressure fluctuates throughout the day. What matters is the average over time. That's why keeping a log is important. One high reading isn't a crisis. One low reading isn't necessarily a problem. Look at the overall pattern. Question 5. Should I reduce my medications on my own if I think they're too strong? No. Never change medications without talking to your doctor. But if you're having symptoms that you think are from low blood pressure, schedule an appointment. Discuss your concerns. Ask to reevaluate your regimen. Most doctors will work with you to find a regimen that feels better. Now let me tell you what happened to Patricia, 76 years old. Patricia's doctor had pushed her blood pressure down to 118/72. Patricia felt awful, dizzy, weak, confused, couldn't think clearly. She was having trouble with daily activities. Her daughter brought her to see me. I checked Patricia's orthostatic pressures. Lying down, 118/72. Standing, 88/54. Severe orthostatic hypotension. We reduced Patricia's blood pressure medications significantly. Let her pressure come up to 138/78. The orthostatic hypotension resolved. Lying pressure, 138/78. Standing pressure, 124/70. Only a 14-point drop. Much better. Patricia's symptoms disappeared. Energy returned. Mind cleared. She felt like herself again. Her previous doctor was upset that we'd let her pressure go so high. But Patricia was happy, functional, living independently. And 138/78 is not dangerous for a healthy 76-year-old. We chose function and quality of life over a number on paper. Let me also tell you about George, 81 years old, because his story shows the other extreme. George had blood pressure of 172/94. He wasn't taking any medications. He felt fine, no symptoms. But his daughter was worried. She'd read that high blood pressure is dangerous. She brought him to see me. I explained that while 172/94 is higher than ideal, For an 81-year-old, the question is whether treatment will improve his life or his lifespan. George had no history of heart attack or stroke, no diabetes, no kidney disease. He was active and independent. Starting blood pressure medications at 81 carries risks, side effects, dizziness, falls. The benefit might be small. We discussed options. George decided to try lifestyle changes first. Reduce salt, increase potassium-rich foods, lose a little weight, walk more. After 3 months, his pressure was 158/88. Better. Still not perfect by traditional standards. But George felt great. We decided not to start medications. Just continue the lifestyle approach. Monitor every few months. George's daughter wasn't happy. She wanted him on medications. But George was comfortable with the plan. He's now 84, still independent, still active. Pressure staying around 155/86. No complications, no medications. For him, this approach was right. The key point is that blood pressure management in older adults isn't just about the number. It's about the whole person, their functional status, their quality of life, their other medical problems, their risk of falls, their wishes. All of these factors matter. There's a concept in geriatric medicine called treating the patient, not the number. This means looking beyond lab values and measurements to consider what's actually best for this individual person. A blood pressure of 145/88 might be too high for one 75-year-old and perfectly appropriate for another. Context matters. Individual factors matter. Now comment, treating me not number, if you felt like your doctor is focused only on getting your number down without considering how you feel. I want to see how many people have experienced this. Let me also address the issue of dementia risk. Some studies have suggested that high blood pressure in midlife increases dementia risk decades later. This is probably true. Chronic high blood pressure for decades damages blood vessels in the brain, increasing risk of vascular dementia. But other studies have shown that very low blood pressure in late life is also associated with increased dementia risk. This makes sense based on what we know about brain perfusion. If blood pressure is too low, the brain doesn't get adequate blood flow. Reduced blood flow over years could accelerate cognitive decline. The sweet spot seems to be moderate blood pressure in older adults. Not too high, not too low. For most people over 75, systolic in the 130 to 145 range seems to be associated with best cognitive outcomes. Lower than 120 might increase dementia risk. Higher than 160 probably also increases risk. The middle range is safest. This is another reason why blindly aiming for 120/80 in all older adults might be harmful. We might be increasing their dementia risk by reducing brain perfusion. There's also the issue of white coat hypertension I mentioned earlier. Some people have normal blood pressure at home, but high blood pressure in medical settings. The stress of being in a doctor's office raises their pressure temporarily. If doctors only see the high office readings, they might overtreat. They might push blood pressure down to levels that are too low for that person's actual baseline. This is why home blood pressure monitoring is so important. It gives a much more accurate picture of your true average pressure. If you have white coat hypertension, your doctor can adjust your treatment based on your home readings, rather than office readings. And there's the reverse phenomenon, masked hypertension. Some people have normal blood pressure in the office, but high blood pressure at home. This is dangerous because it might be missed. Home monitoring catches this. If your office pressures are normal, but you suspect your home pressures are high, check at home regularly and bring those readings to your doctor. Now let me give you the complete summary. This is what you need to remember and what you need to discuss with your doctor. For most adults over 75, systolic blood pressure of 130 to 140 is associated with best outcomes. Lower than 120 increases risk of falls, orthostatic hypotension, acute kidney injury, and possibly dementia. Higher than 150 increases risk of stroke and heart attack. The sweet spot is the middle range. For adults 65 to 75, targets can be slightly lower. Systolic 130 to 140 is still reasonable. Some healthy 65-year-olds might do well with systolic around 120 to 130. But if symptoms develop or orthostatic hypotension appears, A higher target is better. For frail older adults, regardless of age, preventing falls is the priority. Targets should err on the higher side. Systolic 140 to 150 is often appropriate. Function and independence matter more than hitting a specific number. For older adults with diabetes, prior stroke, or heart disease, targets need to be individualized. Generally, systolic 130 to 140. Occasionally lower if tolerated without symptoms or orthostatic hypotension. Close monitoring is essential. Diastolic blood pressure should generally be kept above 65, ideally 70 to 85. Very low diastolic reduces blood flow to the heart and brain and should be avoided. Orthostatic hypotension is often more dangerous than moderately elevated blood pressure. Check for it regularly. If present, medications likely need adjustment, even if lying blood pressure seems acceptable. Comment, I understand. If you've followed all of this and understand that blood pressure targets for older adults should be higher than traditional guidelines suggest. Comment if you're going to discuss this with your doctor at your next visit. Now let me tell you what happened after Eleanor's death. Her daughter filed a complaint with the medical board, not because the doctor was malicious, but because he was following outdated guidelines. He didn't know that 120/80 might be too low for a 78-year-old woman. The medical board investigated. They found no wrongdoing because the doctor had followed standard care protocols. But the case prompted the medical board to issue new guidance. They sent educational materials to all physicians in the state about blood pressure targets in older adults, about the risks of overtreatment, about checking for orthostatic hypotension. Eleanor's daughter told me, I can't bring my mother back, but maybe her death will prevent others. Maybe other doctors will learn that lower isn't always better for seniors. Maybe other families won't have to go through what we went through. That's why I'm making this video, to spread this information, to help seniors understand that their blood pressure targets should be different from younger people, to help them have informed discussions with their doctors, to prevent unnecessary falls, injuries, and deaths from overtreatment. If this video gave you information that could prevent a fall, that could help you have a better conversation with your doctor, that could improve your quality of life, please share it. Share it with your friends who are over 65. Share it with your parents. Share it with anyone you know who's on blood pressure medications and experiencing dizziness or fatigue. This information could save a life. Subscribe to this channel, because my mission is giving you accurate, up-to-date medical information that your doctors might not know yet. Guidelines are slow to change. New research takes years to filter into practice. I'm bringing you the latest research now, so you can make informed decisions about your health. And comment one of three things. 1. Comment too low if you think your blood pressure might be too low for your age. 2. Comment perfect if you think your blood pressure is in the right range after watching this. 3. Comment talking to doctor if you're going to discuss changing your target with your doctor. Then bookmark this video. Come back to it. Review the target numbers. Review the protocol for checking orthostatic hypotension. Share it with your doctor if needed. This video could be a turning point in your blood pressure management. The moment you learned that higher might be safer for your age. Thank you for watching all the way through. You now know the truth about blood pressure targets for older adults. You know that 120/80 isn't right for everyone. You know the specific targets for different age groups. You know how to check for orthostatic hypotension. You know what to discuss with your doctor. Use this information. Advocate for yourself. And don't let anyone tell you that one number fits all. I'll see you in the next video where we continue taking control of your cardiovascular health together.